Good evening. It's Monday night, so welcome to the uh, first online session, and this was our second class. Um, I'm Professor E.J. Rovella. It's Monday night, and welcome to Healthcare Patient Encounter Perspective. So we're talking about the patient's perspective and the counter side, counter argument to why those things might happen in healthcare. So overall, let's go over the fact that everybody has had some sort of healthcare experience. Um, Unless you were born at home, it's a possibility, and been perfectly healthy, it's possible you might not have been too much in the healthcare system. But one of the things in here, so birth, well visits, sickness, injury, but if you're here at Lehigh University, odds are you've had your vaccinations. So you've had at least some aspect of touching into the healthcare system. Um, let's see. Uh, Challenges in healthcare can be numerous. One of the things I find one of the most ironic is like you go to a doctor's office and know you're going to be in a waiting room. So when should waiting be something that you should expect in any kind of service that you receive? It happens so often, it's actually named the waiting room. We just get used to how inefficient that could be. And so we'll dive into some of the reasons behind why something should be taking so long for its customers to receive a service. Um, Something else that's fairly common is um, getting more than one bill. Do you know that there's multiple people and multiple entities and the way things are organized that create multiple bills, assuming that there weren't mistakes in how the bills were made in the first place? Medication costs, anything you see advertised on the TV, just know it's extremely expensive. Probably on average cost of anything you see on TV is somewhere in the neighborhood of uh, three to $300 to $3,000 a month in the medication costs, even though you may only pay a $30 copay. I mean, those medications average over $1,000 a month in true cost. And a lot of times we see headlines, medication errors, another big challenge. And sometimes it's not as simple as one little thing. So we'll kind of go into this course over several different things. Um, One of the things that I had you take a look at is some videos, particularly comparing U.S. healthcare to how a dog, an animal, receives healthcare. And another one that's really important for you to see is the video from Cleveland Clinic on empathy. So the first thing we mentioned about sympathy, and here just trying to discuss it, is it's actually that feeling of sorrow, pity over someone else's misfortune. You see somebody, they fall and they've got hurt, you feel sorry for them. That's more superficial. So we get into more of empathy. All right, next slide here is empathy. That's the next layer in understanding where something is wrong. So you're understanding the perspective, the way somebody else sees the world. Um, so if it's not just about, oh, somebody fell, I feel sorry for them. It's understanding, okay, this is what it looks like from that person's perspective, and truly seeing it the way the world that they see it. Um, what we're going to dig deeper more so into here is really the system issues, all the things that come together to make those kind of scenarios happen. Whether it's somebody receiving a bill that they might not be able to afford, you might feel sympathy for them. Understanding that like they're just trying to get something basic done, and look at all these things that have overwhelmed them, and that would be more the empathy behind it. And then the system side, which is really where we want to look at, is how many different parts of of a healthcare system actually send out bills. How complicated is it actually to for an organization to receive payment for services that are provided? So that's where we're going to dig a lot more into this semester. Okay, so I just given a brief example about system. Here's something where I want a little more audience participation. We're going to go over some examples. And that's one of the things that you should know about the class too, is that everybody's can participate. And just so you know, from my perspective, like it's not always naturally comfortable for me to get in front of an audience to speak. So I understand that not everybody's talkative. So we'll work through it. But it's really important that I want everybody to talk through, think about something, say the wrong thing, it's a safe environment. We're not here to make fun of anybody, but we want to learn from each other and build off of it. So first, what I'm going to do is just kind of go randomly through the list, make sure, and let's see, list-wise, I'm going to pick Jason. All right, so Jason, I want you to give me an example of what you think a system aspect of healthcare is and how it might touch a patient. Okay, so one of the things I brought up earlier today was the example of the waiting room and how it happens so often that it's actually named the waiting room. Uh, so there's some system reasons behind that. So we're going to touch on briefly here. Provider efficiency. So you go to a doctor's office, and for that doctor, and when I say provider here, I want to make that clear. So defining that, a provider can be a physician, nurse practitioner, physician assistant, anything that you're going to get billed for doing it. So it could even be a registered dietitian, um, diabetes counseling. There's a couple different reasons why you might be seeing somebody else other than a physician. But for the sake of waiting room, this example, we lump it in under provider. So any organization is trying to make the most of the assets they have, and you've got a doctor, so let's try to fill every bit of their availability. In order to do that, you're piling up inventory of patients to be processed. So just like you're manufacturing a widget, a hammer, you line up in your inventory all the pieces of wood, all the pieces of metal, all the nails, whatever it takes to go in to make that hammer. So you're seen as a patient as the handle to that hammer. And let's stack you up in the warehouse. Well, that warehouse is the waiting room. And that ensures that all the resources are there ready to flow so that doctor can make the most amount of hammers in their time. A big part of driving that too, even if it's not some aspect of administration directly giving a physician an order to how to fill their slots, which often does happen. Um, there's often indirect matters of affecting that under provider compensation. So a provider is typically paid either a salary, but a lot of times those salaries are based on certain levels of productivity, units of efficiency. If you go back to a private practice model, which there are a few physicians still in, they send out a bill for a service they provide, they get payment for that. So they're building their compensation volume off of revenue. One of them, a much more common model of compensation is based on RVUs, relative value units. So CMS has set up a value for each billing code. Each billing code can range, so it's trying to judge how much it takes in terms of time and resources, and a simple visit versus a complex visit will have different RVU values, different levels of values. Either way, and between those systems, then we are talking about incentivizing a provider to see more, do more work to either justify their current compensation or allow them to achieve higher levels of compensation. The counter perspective on receiving more than one bill. Okay, so for any women in here, well, for it's still relevant to men. But if you're thinking about having a child, say you go in and you are in labor, you give birth. Do you know that you will be seen by the obstetrician, who you've seen before in that case, will drop a bill. You'll get billed for that. There's also a hospital charge for being in the hospital. There's anesthesia. That's a separate physician. So in most hospital systems, they may employ some physicians. They may even employ the obstetricians. Typically, the anesthesia is not somebody that's directly employed. So they're dropping their own bill that's completely separate from the hospital. And in some cases, that anesthesiologist may have a CRNA, a registered nurse anesthetist, that may actually work for the hospital, but a different part of the hospital. So you could easily receive 4 bills for one experience of giving birth. Now, that's also assuming that you don't receive more than one bill based on how billing is organized. So billing is a separate department. They receive information internally that a service was provided. They put that together. It's no longer a paper form in most cases, it's electronic. It goes off to your insurance company. The insurance company may send something back and say, we're not going to pay for it because something wasn't documented appropriately. Then in that billing department, they could take that bill and send it on to the patient. But in the meantime, they submitted some more information, and now the insurance company paid for part of it, but not all of it. They could send it back. You could receive another bill. You could receive bills just for the level of complexity of what happens in our healthcare billing. Now, anybody who's age 65 and up now becomes eligible for Medicare. So Medicare at most is going to pay for 80% of a service. So many people have a secondary insurance that might cover some other level of payment. A lot of Medicaid patients could be dual eligible for Medicare and Medicaid. So the level of complexity in defining who should be paying for the service that was provided can be very complex, and it's very easy for it to be confused as to who owes what. So it's so complex you should almost assume that it gets done wrong. Counter perspective, we're talking about medication costs. So for profit, most pharmaceutical companies are for profit. They're trying to make as much money as they can. They have a fiduciary responsibility to their shareholders to try to make the most of what they have. Most of that is charged towards United States more wealthy clients, customers that can pay for medication. Most of that is justified for research and development, and it's true. They spend millions of dollars to try to develop new drugs. But also every bit of commercial advertising you see, you're paying for in the price of the medication as well. Government policy, one thing of note. So Medicare does not require any kind of, there is no negotiation for pricing, but the Veterans Administration, that people who are under that benefit system, let's say you have acid reflux, and there are several different types of medications that can treat that. The Veterans Administration, what they do is negotiate on annual, multi-annual basis and approach the different manufacturers of the drug and say, we could use your drug or we could use your competition's drug. I want you guys to bid, and whoever gives us the best price for the best product. And so when the doctor in the VA system wants to prescribe a medication for acid reflux, for heartburn, for one of their patients, they have to choose the one that the larger organization has negotiated to get the best price. Medication errors. So a whole host of things that can relate to that. There are a lot of regulations that go into place as far as documentations. There are accrediting bodies that go through and say, okay, any medication that's given, you should be using certain parameters on how you check to make sure you're giving it to the right patient. There are different organizational structures. There could be, so how the pharmacy is organized in a hospital is different than how the nurses are organized. And what may work in the most efficient manner for the pharmacy may not get communicated at all to the nursing department that actually has to administer it. And if you're in a physician group and you're a nurse in a physician group, even though it may still be all under the same entity, it may be organized completely different. They, more than likely, the physician's organization is actually purchasing their medication from a different organization than the hospital's pharmacy is purchasing it. So you could have a name brand drug, you could have in one organization, and you could have the generic drug. They could, same effects, same medication, labeled different ways, coming from different suppliers. So there's a lot of avenues for where things can get confusing there too. So as far as presentations, it's the next step, and we've got a couple coming up today, but I want to give you guys a couple of resources for when you present. We're talking about the patient side of things, but and then as we go after that, we have the forums, and I want you guys to look at Modern Healthcare is a good resource for just getting overall current event public opinions of what's going on in healthcare. Do research through our library system, and Google Scholar. Good, easy ways to kind of just build, you have this thought, let's look somewhere and kind of build some references, because I want our forums, our discussions to be beyond just opinions, but like looking and getting understanding for it and a lot of counterpoints. So for the rest of the week, that's where I want you guys digging deep into what the topics are that are presented and how we can learn more about it. So up today for presentation first is Julie Dillon. So we're gonna let her go through her topic and then take notes, digest it, and then we'll be able to discuss it a little bit more in the forum later in the week.